Welcome back to the Critical Care Survival Guide. We're seeing lots more ARDS nowadays in our patients with this outbreak of the SARS virus. This video is designed to help you diagnose ARDS and get you started on treating these patients when they're on mechanical ventilation. Let's get going. So ARDS is acute respiratory distress syndrome. It's acute. These people come in with days of symptoms, not weeks. You make the diagnosis by first looking at the chest x-ray. And on the chest x-ray, we want to see bilateral infiltrates. Importantly, we do not want these infiltrates to be from congestive heart failure. So you look at their echo, you look at them clinically, maybe their BNP. If you have a SWAN, you can use that. Make sure that this is not cardiogenic pulmonary edema. By definition, ARDS is non-cardiogenic pulmonary edema. The next thing we look for is we want a cause. Typically, this is sepsis. Nowadays, we're seeing lots of SARS, COVID-19 causing this. And finally, and very importantly, you look at the PaO2 to FiO2 ratio. If the ratio is less than 300 and you meet these other criteria, you have ARDS. Importantly, if the ratio is less than 150, that's a key number we're looking at to see if somebody may benefit from prone therapy, which is a way to improve oxygenation in these patients based on a 2013 New England Journal study. So these are your 4 criteria for diagnosis. What's next? When you're setting these patients up, after you've made the diagnosis, after you've intubated them safely, limiting aerosols, you want to think about how to set things up on the ventilator. One of the key things we know is that we want to target 6 milliliters per kilogram ideal body weight. That's a key number because as patients get larger, their lungs don't get larger. Your lung size is predicated on your height, so it's ideal or predicted body weight. Number 2, we like to keep the plateau pressures less than 30 as we can. What's the plateau pressure? Well, as air goes into the lungs, the plateau pressure is the end inspiratory pressure, so the pressure when the lung is fully inflated. It is reflective of lung compliance, as we'll learn about more here in a moment. In addition to these things, there's other things we should be doing, treating underlying causes, conservative fluid therapy, that kind of stuff. Next, once someone's on the ventilator, you need to pick the mode, you need to pick the rate, you need to pick the tidal volume and the FiO2. We have control over tidal volume, we have control over mode, we have control over something called PEEP, which is the positive end expiratory pressure. So as air is now coming out of the lungs, PEEP is the pressure left over after the air is eliminated. The more PEEP you have, the more the alveoli will be splinted open, giving more time for oxygen to diffuse across. So PEEP is a key metric we can set on the ventilator in addition to tidal volume. That's important. We're finding that patients with ARDS, they do better, they oxygenate better with higher levels of PEEP. You can start your PEEP by looking at PEEP charts that are published from ards.net. You can also titrate PEEP and tidal volume to help you decrease those plateau pressures. Let me give you an example. All lungs are not going to be created equal that have ARDS, all right? Some lungs, as the air goes in, are nice and compliant, no problem. These lungs can handle a normal tidal volume, let's say 500. Lungs, however, that have ARDS, they have a problem. They have a bunch, of disease making up the lung, such that if you try to put the air in at the same tidal volume in this baby lung, so to speak, you can blast open or over-distend some alveoli. That can lead to more cytokine release and more problems. This concept of a baby lung is why we like to take tidal volumes and lower them to try to say that 6 mils per kilogram in order to accurately deliver the tidal volume at the size of the lung that you're dealing with. So that's one important key about low tidal volumes and keeping those tidal volumes down. The more that you're over-distending alveoli, the higher the plateau pressures go, and that's when you can be creating barotrauma or volume trauma. Lastly, an important concept you need to understand, if you can't lower the tidal volume, another thing you might need to do is recruit lung. All right, lung that's been filled with non-cardiogenic edema, maybe the surfactant's dysfunctional, we want to pop open those alveoli to help us oxygenate a little bit better. The concept here relates to the volume, tidal volume on the y-axis, and the airway pressures on the x-axis. Say we take at a given PEEP, remember positive end expiratory pressure, and a plateau. That's going to be the difference as air goes in, end exhalation to end inhalation. If we chart the compliance of the lung, CRS, we can plot it against the patient's tidal volume that they're getting. So at this given tidal volume breath, let's call it 400, you have a delta in between the PEEP and plateau. This delta, or delta P, is called the driving pressure. And importantly, the driving pressure is intimately related to the tidal volume and the compliance of the respiratory system. Watch what happens now. I'm going to take the same patient who we're delivering 400 to. I'm going to change their compliance curve. I'm going to make their curve very artsy, lower lung compliance. Let's call it curve A. In this patient, for the same given tidal volume, your driving pressure is going to markedly increase because as you increase or decrease, I should say, lung compliance, you're going to have much higher pressures at a given tidal volume. If you were to say increase PEEP on this patient, you would notice that their plateau pressure is going to shift and their delta P is going to get much higher. This is a sign that you are potentially overdistending alveoli. This is a sign of a very diseased, low compliant lung. On the converse, let's take a look at this lung, lung B. Here, if we keep the PEEP, let's say whatever level you have it set at, for example, seg 10, and you look at how the lung responds, notice that the delta doesn't change. That's important because this is showing us that in curve B, this is lung that's recruitable. As you inch up on the PEEP, if your driving pressure, your delta V, delta P, does not increase, that's a sign that you're recruiting lung. You're popping open alveoli without overstretching them. So I want you to diagnose ARDS and I want you to ventilate safely. I want you to use low tidal volumes and I want you to go up on PEEP as you can to recruit lung without overdistending and causing lung damage. Thanks again for watching. If you like these videos, don't forget to subscribe.